Good afternoon. I'd like to, first of all, thank Economic Times for doing this web-based lecture. And I think having the World Liver Day tomorrow, I think they've got a series of lectures, if I'm right. And the lectures are going to cover some of the most important topics in liver diseases. And today my lecture is about fatty liver disease. Now, fatty liver disease is really defined as any fatty infiltration more than 5% of hepatocytes within the liver. Now, there is another condition which causes fatty liver disease, which is alcoholic liver disease. And I'm not going to talk about it because it is a subject on itself. So we'll talk about a condition called non-alcoholic fatty liver disease. And here, it's important that alcohol is excluded as a cause. Now, fatty liver disease is a new disease, the non-alcoholic fatty liver disease. And it's come about as a result of our lifestyle. If you will remember, in your own lifetime, your grandparents wouldn't have had access to so much food as we do now. And also, I mean, we are created as hunter-gatherers. We need to be fit, we need to find our own food. But everything has probably changed in the last 100 years, and we are probably not adapted to it. And really, this excessive amount of food, which has resulted in this new disease, and actually the first description of the histological features of this disease was only described in 1980, really as early as 35 years ago. And this again excludes patients who consume alcohol. But why worry about fat? I mean, storing fat is really an important aspect of our nutrition. But when fat is stored in our liver, it is not an innocuous substance. It actually causes damage. And it's seen in our population in around 30% of the adults and 13% of children. It's actually even worse in children than in adults, and childhood obesity is on an increase in our population now. And they've got to live a long time, and when they are obese as children, they continue to be obese as adults. And as I said, fat is not innocuous. It results in damage and converts this fatty liver disease into a condition called NASH, which is steatohepatitis. Now, there is inflammation in the liver, and this inflammation can progress on to damaging the liver to a state of cirrhosis. Now, what about just damage to the liver? Is that an issue? Yes, it is an issue, as you will see in this slide, that once you've got NASH, not just fatty liver disease, the chances of mortality or the chances of being alive at 10 years diminishes significantly to 38%. And it's even worse in the alcoholic fatty liver group, where the chance of being alive with fatty liver disease is around 15%. So it significantly reduces the life expectancy, and we'll see what these reasons are. So you start with the normal liver, and all of this lifestyle changes, excessive consumption of really carbohydrate food, junk food, have all resulted in fatty liver disease, and the progression of fatty liver disease is to a condition called steatohepatitis, where there is, in addition to fat in the liver, you get inflammation and fibrosis, and that can lead on to cirrhosis over a period of time. And the final picture is that of end-stage liver disease due to cirrhosis, or in some instances, even hepatocellular carcinoma. Now, this is a publication from our population, and you will see that it's a new disease, I said, only described around a little over 30 years ago. It's already replacing other causes of liver disease. Hepatitis B and hepatitis C used to be the most common cause of liver disease, and fatty liver disease has overtaken this as a major cause of death due to liver disease. And it's also in our population one of the most common causes of hepatocellular carcinoma. Now, fatty liver disease is also a worldwide burden, and it's been on an increase significantly in the United States and Europe, where again the consumption of junk food, an excessive amount of food, and obesity are very common in the United States. we may have a significant proportion of the population who may not be feeding well, but amongst the reasonably well off, the middle class and the upper middle class, obesity is very common. And you will see that in greater than 30% of the patients, there is likely to be fat within the liver. And again, if you look at the eastern part of the world, China, Japan, India and Sri Lanka, Indonesia probably rank very high, where the incidence of fatty liver disease is very common. But in our part of the world, there is something very unique, that in the Western world, patients have to be obese with a BMI of greater than 30 to have fatty liver disease. Whereas in our part of the world, there is no need for them to be obese. Fatty liver disease is seen in non-obese individuals, people who have, you've seen, a big tummy with visceral adiposity, rather than really subcutaneous accumulation of fat that you see in Caucasians. And this again increases the risk of fatty liver disease much more in our population. Now, what is the natural history of fatty liver disease? Now, if you start off with a normal liver, we see that fatty liver disease is seen around 30% of our population. And once you've got fatty liver, the progression from fatty liver to NASH happens in an additional 30% of individuals. Now, this situation is somewhat reversible situation. It is not such a bad state to be, provided the people can look after their health with exercise and also with better living with healthy food. But once fibrosis sets in, which again happens in around 30% of the patients who develop fatty liver disease, then it's an ongoing process, and it goes on to cirrhosis, and probably in 10% of patients during their lifetime, they will also form hepatocellular carcinoma. I think I find that fatty liver disease is probably one of the most common causes of hepatocellular carcinoma in our part of the world, and a significant proportion of these patients will also die of liver failure. Now, what is the risk factor or the predictors of progression from NASH to fibrosis? And this is generally people who are more than 45 years of age, who have a BMI, at least in our population, of greater than 28, and have a degree of insulin resistance, or probably even have diabetes and have hypertension. So if you have these risk factors, there's a very high incidence of progression from NASH to fibrosis and again to cirrhosis. And progression to fibrosis and cirrhosis now significantly reduces the life expectancy of these patients. If you look at these graphs, if there is no fat over a 20-year period or 24-year period, there is not a significant mortality. Maybe there is a 10% mortality, which may be due to other causes. Once NASH is diagnosed, there is probably a 50% mortality over a 20 or 24-year period. So it is important because this is a significant reduction in the life expectancy in these patients. If you look at who are the patients who are likely to die amongst those who have NASH, fibrosis is very important. Patients who have got F4 fibrosis, again, have a significantly increased risk of mortality. And if you look here, around at 12 years, they have around 45% risk of mortality. The survival figure at 5 years for them, 12 years for them, is in the range of 55%. So having a fatty liver and progression to fibrosis significantly has an adverse effect on their life expectancy. Now let's look at the causes of NAFLD. I mean, NAFLD comes as it's part of a metabolic syndrome in our population, and this is called primary NAFLD. And metabolic syndrome, as you know, are individuals who have a BMI, who are obese, who have a BMI of greater than 30, who may have hypertension, will have hypertriglyceridemia, low HDL, and associated diabetes mellitus. And this is part of a syndrome of metabolic syndrome. And if you look at the association of hypertension and diabetes, so when somebody's got no hypertension and diabetes, even though they may be obese, their incidence of NASH is significantly lower at less than 10%. But with hypertension, the incidence of NASH increases to 30%. With diabetes mellitus, it increases to 60%. And combination of diabetes and hypertension, you can see the incidence of NASH goes up to around 75%. Now, there are also other causes, secondary causes of fatty liver disease. We already saw alcohol as an important cause of fatty liver disease, but there is also other metabolic disorders like Wilson's disease, hepatitis C virus, some of the drugs, TPN, and even obesity surgery, which involves bypass surgery. There is an increased incidence of fatty liver disease and NASH in these individuals. And that's why it's very important that one needs to exclude these things when you're looking at fatty liver disease. Now let's look at the pathogenesis of fatty liver disease. Now, I think the primary problem in this is insulin resistance. When there is insulin resistance, there is excessive accumulation of fat and there is beta oxidation, and there is excessive accumulation of free fatty acids. And this results in the release of free radicals. And these free radicals, in turn, causes an imbalance in the mitochondrial membrane, resulting in imbalance between the free radicals and the antioxidants, which results in release of pro-inflammatory cytokines. And that's what results in really cell death and apoptosis. This is just a schematic representation showing what is happening in the mitochondrial membrane. The excessive amount of free acid that is released results in really reduction in the respiratory chain enzymes, an increase in free radicals, and cytokines, which results in apoptosis. And once you've got cell death, and then you get fibrosis that you see in other causes of liver diseases as well, and then leading on to cirrhosis. Now, how do we approach a patient with fatty liver disease? I think what's most important is awareness. There are many obese people floating around who have no idea that fatty liver disease is a risk factor in them. Many of these patients will turn up to your clinic with the first diagnosis of hepatocellular carcinoma, not even knowing that they've got an underlying liver disease. And then we'll talk a little bit about diagnosis and treatment and how to follow them in the long term. So awareness is the most important. And who do you target? Who do you really educate? Which is the population? I think in general terms, it's metabolic syndrome. Those are the individuals you need to target. And in simple terms, anybody with a BMI of greater than 30 needs to be investigated to exclude fatty liver disease. Otherwise, if they don't have a BMI of greater than 30, which is very common in our part of the world, why you get fatty liver disease with lower BMI, you need to have 2 of the following, 5 that you see: triglycerides of more than 150 milligrams per deciliter, HDL cholesterol of less than 40, a systolic blood pressure of greater than 130, and a fasting blood glucose of greater than 100 milligrams per deciliter. So these are the group of people who need to be targeted, investigated, really counseled, and further investigations need to be done for that. In terms of clinical history and also symptomatology, most of these patients are actually used to that overweighting. They don't perceive it as a big problem. They have very little symptoms to give you unless you probe them and ask them the history. I think the history of sleep apnea is important. And also, it's very important to differentiate this from alcoholic fatty liver disease. Just sitting in front of them, asking them how much alcohol they consume may not be adequate. I think it is important to have a proper questionnaire and a detailed inquiry into their alcohol history is very important. And again, physical examination may not reveal much in these patients at all. If you look at really the liver function test in the fatty liver disease NAFLD group, when there is no NASH, the enzymes and serum bilirubin is likely to be normal. The alkaline phosphatase and the gamma GT may be slightly abnormal, but in the NASH group, where there is an inflammation, the enzymes, both the ALT and AST, are likely to be 2 times normal. This is not an uncommon finding. And in all of these patients, when patients come to you with abnormal liver function tests, particularly with abnormally elevated enzymes, it is important to exclude other causes of fatty liver disease, other causes of liver disease in general. Now, what are the imaging modalities available to diagnose fatty liver disease? I think the first evidence of fatty liver disease comes from a simple ultrasound scan. A good ultrasonographer should be able to say that this is a fatty liver, and then further investigation will really depend on further axial imaging. Now, both CT scan, a plain CT scan, and an MRI scan are capable of diagnosing fatty liver disease. You may even, in some ways, be able to quantify to a certain extent the extent of fatty liver disease. But the biggest problem with them is it's very difficult to distinguish fatty liver disease from NASH or from alcoholic steatohepatitis in these patients, because the importance is not in the diagnosis of fatty infiltration in the liver, but to distinguish fatty infiltration from NASH. Now, there are many non-invasive ways of really diagnosing NASH, and one of the scans that is very commonly used and very popular in the last 5 or 6 years is a FibroScan. FibroScan is able to not only tell you the diagnosis of fatty liver disease, also it will tell you the amount of fibrosis, and as you can see here, the fibrosis level of more than 12 or 13 kilopascals will have severe fibrosis in them. And more recently, people have come up with MR elastography in the 3 Tesla machines, and these are also very useful, like FibroScan, to be able to not only quantify the amount of fat, but also estimate the degree of fibrosis in them. And here is an example of MR elastography, where you see in the first row mild fatty infiltration, in the second one you've got inflammation, NASH picture, and the third one you can very clearly see severe fibrosis being diagnosed from MR elastography. But at the end of the day, I think these are all really work in progress with any amount of literature published in them, but the gold standard for diagnosing NASH and the gold standard for diagnosing cirrhosis is always going to be liver biopsy. But you do need to be cautious about liver biopsy. I don't think one should be doing liver biopsy in all of these patients, and I think liver biopsy is needed only for those patients where we saw that patients with NAFLD who are at very high risk of steatohepatitis and fibrosis. So this is the only group of patients where liver biopsy is indicated. But liver biopsy is again certainly indicated when you've got a doubt as to the diagnosis, or when you feel that there may be other causes of fatty liver disease, the secondary causes that we saw earlier on in that list. Such patients may need a liver biopsy. Now, there are a number of treatment options available. I think the most important treatment option is going to be really change in their lifestyle and diet. That would be it. And we'll also go through the other available options, treatment options, one by one. It's very clear weight loss is the most important and the most effective treatment option. And weight loss will have to be a combination of reduction in the calorie intake as well as increasing the physical activity. And a weight loss of probably around 5% will significantly improve the steatosis. I generally actually ask patients to lose around 10% of their body weight, and even for the inflammation to settle down, you may require that amount of weight loss. And quite often, if you tell them 10%, people will try and do at least 5%, which could significantly improve their fatty liver, both biochemically as well as histologically. Now, metformin has been used as an insulin sensitizing agent. In the pathogenesis, we saw that insulin resistance is a very important aspect of the pathogenesis of fatty liver disease. But I'm still sure many use metformin as one of the modalities of treatment of fatty liver disease. But there isn't a lot of evidence. Metformin has no significant effect on liver histology and currently is not really recommended for the treatment of NASH. What about vitamin E? We also saw there is a significant amount of oxidative stress from increased triglycerides within the mitochondria during the beta oxidation process. And vitamin E is actually a very good antioxidant. So it sets the balance right. And this has been investigated very much in the treatment of NASH. And there is a very important publication by Samuel et al. In the New England Journal of Medicine, which is very clearly shown that the use of vitamin E is associated with improvement in the enzymes in NASH. It can cause improvement in steatosis and inflammation and ballooning, and it has got no effect on, however, it's got no effect on hepatic fibrosis, so it's not so useful in the advanced status. So the conclusion of this trial is vitamin E was superior to placebo in adults with NASH and without diabetes mellitus. What about ursodeoxycholic acid? Many still use ursodeoxycholic acid as one of the treatment options for patients with fatty liver disease, but it actually has no histological benefit, and its use is not recommended for the treatment of fatty liver disease. And there is, however, some multi-center study for the use of omega-3 fatty acid for treating NASH, but the results are not out yet, and therefore currently it is not within the recommendation. What about the use of statin in patients with NAFLD and NASH? Now, we saw that the mortality of patients with NASH is significantly improved over a period of time. Fatty liver disease is significantly increased over a period of time. Almost 40 to 50% mortality in 10 years' time. But a significant amount of this mortality doesn't come from liver failure. It also comes from associated cardiovascular diseases, stroke, etc. And therefore, statins have been recommended for using in patients with NAFLD when there is associated cardiovascular disease. But many have worried with the use of statins in patients with liver dysfunction, and the AASLD guidelines clearly states that there is lack of evidence that patients with NAFLD and NASH have an increased risk of serious drug-induced liver injury from statins, and therefore they say that they can be used to treat dyslipidemias in patients with liver disease. Bariatric surgery nowadays is quite extensively used in patients with morbid obesity. I don't think there is any contraindications to apply bariatric surgery for patients with fatty liver disease and NASH, and probably even with early fibrosis. The next issue that we need to remember in the management of these patients is all of these patients should be considered and should be managed with liver disease of other etiologies. It's very important that these patients are screened for esophageal varices, and they have their endoscopy as you would in other patients with end-stage liver disease. And it's also very important that they are within an HCC screening protocol and as in other causes of cirrhosis. But there is no role for repeated liver biopsy in these patients. Once you've done a liver biopsy and proved that it is NASH, you could use FibroScan to monitor the effect of the treatment rather than to do a repeat liver biopsy to find out whether the situation is improved. So in summary, I don't think you can read it. I think it's all Greek here for me. What we need to say is the fatty liver disease is currently almost of epidemic proportion, mainly because of obesity, which is on an increase throughout the world. Most fatty liver disease, when it is in the early stages, either at NASH or in the NAFLD stage, is reversible, and it's very important that these patients change their quality, change their lifestyle, change their food habits, and also exercise to revert back to a normal stage. And in the advanced stages, fatty liver disease is associated with cirrhosis, and there is a high incidence of hepatocellular carcinoma in them. And I think there needs to be a work worldwide on education of younger children in order to reduce the incidence of fatty liver disease in young children. Thank you very much. I wait to hear your questions. I don't know if the organizers have looked at it. Mohamed Rela, can I? The last slide was almost like weak. It doesn't matter. It's finished. Somebody's slide. It's okay. Sorry. I've minimized it. Take it out. Now I see you. Okay. Are we waiting for questions? I can't hear you.
Questions are already shared with you.
I can't see the questions. I'll get the boys here to look at it.
Okay, let me help you. I just read down the questions assigned to you. Okay, the first question is from Anusha Gaude. The question is, does a liver grow in a donor in a month who gets an axillary transplant?
This is not related to the subject. The question is, does the liver grow? Say that again. Liver grow in a donor in a month who gets an auxiliary liver transplant. Now, I think it's a very intelligent question, unrelated to the subject. Auxiliary liver transplant is performed for two reasons. The main indication is really acute liver failure. And in acute liver failure, when we do auxiliary liver transplant, the native liver will not grow in a month. I think generally they've probably been told that when you do a liver transplant or when you do a hepatectomy, the liver is capable of growing within a month, whereas in an auxiliary liver transplant, it takes many months and some instances 1 or 2 years for the liver to grow. I don't know if that's answered the question. I think now I've got the questions I can read. Right, this one?
That was the first question.
Yeah, I've answered that question. The second question is, will occasional consumption of wine, beer worsen non-alcoholic fatty liver disease? I think there is a clear recommendation of for amount of alcohol consumption and for the incidence of alcoholic fatty liver disease. But in anybody who's got already fatty liver or NASH, I would strongly recommend them not to have alcohol, which could make things worse. But if your question is, what about a very rare occasion like a Christmas or a Diwali or something like that, I wouldn't stop them from having a glass of alcohol on very rare occasions. But in general, patients who have already got liver disease and cirrhosis, I will not recommend them to consume alcohol. Lab impression of my father, 56. I'm reading the question. Mildly enlarged, 16.5 centimeter. Mild hepatomegaly with grade 2 fatty changes. How to reverse this condition, please advise. I think I've already said that. There's not a lot of information in this question. I presume your father is overweight. If he's overweight, I think it's very important, diet and exercise. His diabetes needs to be well under control. His hypertension needs to be well under control if he's got any of this. And at the level of fatty liver, in the early stages, it very much is reversible. Grade 2 fatty changes should be reversible in the absence of NASH or even with NASH. I think it's all about lifetime changes. The next question is Dr. Amandeep Gupta. How do you see the role of obeticholic acid in NASH? I don't have an answer for that. I have my colleagues here. Can you answer that for me? He says there is upcoming data in this and there is still not enough evidence of it. I think that would be the end of the questions, I'm afraid. Are we finished there? The organizers are waiting for more questions. guys want to make a comment from there? You finish very quickly.
Questions are shared with you, sir.
Already there? The questions are there? Oh, okay. Sorry.
Yeah, questions.
Are there any symptoms of fatty liver disease a layman should know? I think fatty liver disease doesn't have that many symptoms. Some people may feel a bit tired, but when they go on to fibrosis and cirrhosis, obviously they will have symptoms of chronic liver disease. In the early stages, there are very few symptoms. But I think people who are overweight or have central obesity, abdominal obesity, should be really worried about fatty liver and have investigations done. The next is which food, especially when you say vitamin E is very good food for NAFLD. I think vitamin E generally is nowadays available as capsules. What is the food that is rich in vitamin E? Green leafy vegetables. But mostly vitamin E is available as capsules when you want to treat patients with fatty liver disease. Looking at the next question. Is continuously raised SGOT and SGPT for more than 2 years an indication of NASH? I think this is a very good question, probably a common problem. I think if the enzymes are not settled and if you are known to have liver disease, fatty liver disease, and there are risk factors for NASH, you should certainly be investigated further to exclude NASH. I think that the first investigation would probably be your fibroscan and probably your MR quantification. I think it is not normal to have a continuously raised SGOT and SGPT. That certainly needs to be further investigated to exclude NASH. Given that our food is a daily cocktail of poison, that's a good statement. How does it impact the liver and what can be done about it? Now, I think this is a very philosophical statement. Food as a cocktail of poison. I think probably you're right. The thing is, food is not a poison. We all need food to survive, food to live. We need food for energy. Our problem is we don't consume food only for energy and a healthy way of life. We indulge in food. The problem is indulging in food. And if you indulge in food, if you consume, I think there is a belief that fatty food is very bad for you. I think it's not just fatty food is very bad for you. It's also excessive amount of calories in the food that you consume, large amount of carbohydrate that you consume, which is bad for you. I think anything which is excess of what you require is bad for you. It will certainly affect your liver. It will certainly affect your heart, and it's prone for multiple problems. And I wouldn't still call it a poison. I think it is a poison in excessive amounts. I think I've just answered this question. Do you suspect that fatty liver is more due to fatty diet or carbohydrate-rich diet? I think for us, in our population, where we consume a huge amount of carbohydrate-rich diet, the main offending agent is actually a high carbohydrate diet. Because I know that when you have a lot of fatty food, there is a large amount of fat which is handled and stored in our body as fat in the adipose tissue. But if you consume more carbohydrate than you need, we've been programmed to convert this carbohydrate because we cannot store a huge amount of carbohydrate. Only very little amount of carbohydrate can be stored as glycogen in the liver, and it's a very short supply, and therefore we have the ability to convert the excessive carbohydrate into fat and store it as fat. So most of our problem is actually a diet which has got excessive amount of carbohydrate rather than excessive amount of fat consumption. But I don't want to give the impression that excessive fat consumption is good, but that's also bad. But excessive consumption of carbohydrate is as bad. How much effect exercise and diet can have on fatty liver disease can be measured quantitatively? That's a good question. I think exercise has been proven, or a combination of diet and exercise has been proven to reduce fatty liver disease. And quantification is not so easy thing to do. I mean, FibroScan can be used to assess fatty liver disease and also fibrosis. And here you're not talking about NASH with fibrosis and whether that is improving. Probably MR can be useful to assess whether the fat is disappearing. And in some instances, CT scan, plain CT scan with really, they have a procedure called liver attenuation index where you can see some improvement. But I don't think you should be really worried about how much fat is disappearing from your liver to do that. I think if you lose weight and if you exercise and if you feel good, your liver function tests are normal, and if your ultrasound scan shows that there is not much of fatty liver disease, that should be adequate rather than accurately estimating the fat that is in the liver to see whether there is or not improvement there. The next is, dear doctor, my blood tests show ALT results in blood tests is 77 against limit of 13 to 14. How to identify if my fatty liver disease is due to alcohol or due to my diet? What should be the best? I think you will know how much alcohol you consume. So I think it is important to really go to your doctor and have a discussions about your alcohol intake and what the limit it is for you. We need to know your age, your lifestyle, how much exercise you do, what sort of food that you consume to really know the difference. If you think that you consume excessive amounts of alcohol, that will probably be the cause of your fatty liver more than fatty liver disease. But that will require a consultation and really a detailed discussion with your doctor to find out what's going on. Is Cilmerin safe in fatty liver disease? My understanding is people don't use it for fatty liver disease. Dear doctor, I've been treated for, I presume you say NAFLD, for past 10 years. My clinical parameters are TG of 2.9. What is TG? Sorry. Triglycerides at 2.9 millimoles per liter. I'm not familiar with the value, that value for triglycerides. Is usually in the 100 range. Total cholesterol of 5.9, LDL 3.9, LFT, ALT of 94, AST of 36. Total bilirubin is 32.2. That again is in micromoles, I guess. I hope it's not in milligrams. Now doc has given statin 200 milligrams, fenofibrate 160 milligrams every day. I'm scared about these drugs. Will it cause further damage? I don't think the drugs are going to cause you further damage. He is treating your hypercholesterolemia. But I don't think you got your blood test written correctly, because if you've got a bilirubin of 32 milligrams, unless you're in a different country than to India, that's a very abnormal result. So you certainly would require treatment for your hypercholesterolemia, and your triglycerides, according to you, are very low. It's not high. So I don't know what to make out of it. But I don't think you should be worried about these drugs that you're taking. Thank you very much.